And when we look at that joint lining, this is what it looks like. And it's a very interesting, I'll show you in a moment what rheumatoid arthritis looks like. And see these little, little cells on the surface, they're little blood vessels here, and this just makes a filtration of our blood, and it makes the joint fluid there. That fluid, again, is the nourishment for our cartilage. But when we think about arthritis, there are lots of different signs and symptoms. You know, we can have, as you see, the symptoms on the left, the various signs on the right. But the cardinal manifestation that we all have to deal with is pain. And that pain has a tremendous impact on our life. You know, when we take somewhere normally between 3,000 and 5,000 steps a day, you know, at least that number. And every step we take, if we have arthritis in our knee or our hip, you know, that is a reminder about what the problem is. One challenge that we as healthcare professionals have is this spectrum of the rheumatic disease. You know, I was telling someone this morning about a slide I have that shows a picture on one side of a car with a dent. Now, that's a phenomena. It's pretty irritating when you walk out and see a dent in your car. My wife drove out of the garage, and I have a little picture of this, and there on the garage floor was a little bit of oil. That ended up costing $900 because the head gaskets were, you know, leaking. So that phenomena is a disease. And that's a challenge that we have. You know, is it a dent? We know that with the aging process, again, not that any of us are old, but as we get over the age of 50, we can see wear and tear changes in different parts of our body. You know, they are frequently asymptomatic, and how, and as Tony said, and as was explained, LaDonna said to you that, you know, when do you make an intervention? And, you know, I wrote an editorial. It was called The Physician as a Risk Manager. We help you manage risk. You know, what is the risk of going on to develop problems versus the risk of an intervention like surgery? Or of any of the medicines we use. And how do we return people from over there on the right-hand side to the left? And that's the challenge. In the last few minutes, and we'll talk, I'll be coming back for the question and answer. We can discuss various things, but I wanted to just give you an overview of two types of arthritis. One type is the mechanical wear and tear type. This is osteoarthritis. And the other major category is an inflammatory process in which that process, that irritation, occurs in different places, but especially in that joint lining. This is what we see with rheumatoid arthritis, with lupus, gout, and there are other ones as well. We do have conditions that occur around the joints. You know, low back pain is a very common problem. 90% of people will have back pain at some time in their life. You know, tendonitis, bursitis, and certainly this condition in which there can be generalized pain due to sensitivity within the body called fibromyalgia. You know, this slide begins, I want to tell you of this is a 74-year-old woman who we saw in the office, and she really was not having hand pain at all. She did notice that there was some bony enlargement in those outer knuckle areas, and she had a little bit of difficulties with her thumb. This began about 10 years ago, and there was a little decrease in range in her hand, but not a whole lot of symptoms. Actually, she had stepped off a curb. She noted that she had occasional aching in her knees. She loved to get down on her hands and knees and scrub her floors, but had stepped off a curb and began having increasing pain and swelling in her knee. You know, her knee wasn't so bad when she got up in the morning, but as she would use it throughout the day, there'd be increasing symptoms right there, and it really resulted in a significant impairment of her activities of daily living. This is what her x-ray looked like, not unlike what you saw before. And we see over on that left-hand side that the cartilage is gone. That is bone on bone. There is that whiteness, which is the reaction. And so that bone, we call that sclerosis. Sclerosis means hardening. You know, atherosclerosis, hardening of the arteries. Well, this is sclerosis of bone. That little bony plate under there, we have microfractures, and that's the healing, and that's a problem. And this is what we see in osteoarthritis. The normal joint over here with the joint lining and that shock absorber cartilage What happens in osteoarthritis is that cartilage wears away. Now, we don't know exactly why that is, believe it or not. Yes, it is a wear and tear change, but it is not invariable with aging. We have reactive bony changes as well. We'll talk a little later about spurring and the rest. That is one of the ways the body has. At the margins of joints, we get these osteophytes or little bone spurs that we see. And so instead of having that cushion there to walk, we are walking now with a lot more stress being placed on that joint. You know, a great challenge and a tremendous advance in osteoarthritis is what causes it? What causes that cartilage to wear out? What causes the bony change? Well, you know, we do know that with aging, there's an increasing occurrence, but it is not invariable. And there's an enormous amount of research being done now to take a look at genetics and all of the other factors. And hopefully we will be able to understand this better so that we can better target. I don't know if you remember Dolly the sheep. You know, Dolly, this is her cloner, you know, and actually cloning is unbelievable. You know why Dolly was called Dolly? You know, Dolly was cloned from mammary cells, and it was named for Dolly Parton. That was how, so that was it. But Dolly actually died at age 7, and Dolly had significant osteoarthritis of her hips when she died. She also had lung disease. Unfortunately, Dolly was fed a great deal because she had quite a notoriety, and so she would stand up on her back legs, and that may have been part of the process. So in terms, but it turns out that Dolly's genes were the same age as her mother's. So remember that. This cloning thing is not ideal because what happens every time the cell divides, a little hunk of it's cut off. It's called little telomeres. And so there are lots of challenges right there. And so when we look, you know, at this is a slide to show that there's lots of stresses and trauma plays a big role in osteoarthritis as well. This person up here is going to get osteoarthritis of his nose, but so this is what all of us here deal with, is we are looking at these insults, the different ones, how the repair process, unfortunately, it can be slow, but how do we work in here? And that's a great challenge because when we look at the goal of management, we want to improve your pain and improve function. And that's very important because pain and function, as we all know, are very interrelated. And this is a great challenge, again, that we have, is that the course of osteoarthritis is very variable. You know, when do we take what intervention? You know, you'll hear about today of different medicines to do, and we can see this is our pyramid right here. We need, you know who's in charge of your care? You know, I ask all my new patients, so who's in charge of your care? You know what? You are. You are the captain. Your significant other in your life is the first mate. We are your navigators. We must help you. You know, you wonder why, not that anybody ever waits in my office, you know, but we are, we try, but it's very challenging because, you know, it takes an enormous amount of energy, you know, to be able to empower you to figure out what we should do. You know, for internists and rheumatologists, we do use these NSAIDs. This is the first slide I ever made, 1978, and this is all we had when I graduated. It's unbelievable. There was one week, by the way, that Nalfon, Naprosyn, and Telectin came out. And Naprosyn, by the way, is a leave. That's the only one really left that we use. We don't use Naprosyn and Motrin. And so it's a real challenge, and we have now all of these, and which do we do? You know, and it's a challenge of balancing all of that to find out. In the last minute or so, I just want to show you about one other condition. This is what rheumatoid arthritis looks like. And we can see here that we see this swelling and the stiffness here that goes throughout the body. And rheumatoid arthritis, we can see here, can significantly damage the joints. And we see the erosive changes. And the problem is here is that inflammation occurs in this joint lining. And that joint lining not only makes abnormal fluid, but it can actually erode into the bone. And this is what it looks like. Here's that synovium that I showed you what it looked like, and it actually goes right in there. And rheumatoid arthritis, unfortunately, has a tremendous tendency to progress. And what we have to do is to figure out how to influence this. This shows you just a slide, not to be overwhelming, but now these are all the little